this is a very important IC for a refractive surgeon, because most of us are already doing refractive surgery, and most of us who are present here want to start their refractive surgery. And even when I'm doing refractive surgery for so long, I'm always confused per case. So every case should be customized, and we are trying to clear those doubt as much as possible. Dr. Raghav is going to take a first session. The IC is on post laser vision ectasia, correction ectasia, and he will be covering the red flags in pre-laser vision correction workup. So may I invite Dr. Raghav? He's a cataract refractive surgeon in Center for Sight.
Thank you, Dr. Tulika, for this wonderful opportunity. So today I'll be speaking about red flags in a pre-laser vision correction procedure. So our job basically is to reject and find the right candidate for the procedures. So the purpose of my talk will be to find the right candidate, and more importantly, to reject the right candidate. So rejecting is more important than finding the right one. So of course, what cornea are predisposed to a LASIK ectasia? It could be a cornea that is already destined to manifest ectasia later on, cornea which do not have any apparent changes in the cornea preoperatively, but might out in the future. So such a patient, if we operate and then the patient tends to go towards ectasia, will have an ectasia. A preoperatively weak, that is a baseline, or I would say a borderline topography that undergoes surgery, and a relatively normal cornea which is weakened beyond its safety margins. That is, if we go beyond 40% of percentage tissue altered, that could undergo an ectasia. So we have to evaluate our patients very well. Most and foremost important is, of course, the history. Whether the patient has any particular, if the patient is on any particular medication, any family history of ectasia, any family history of corneal procedures, any family history of any corneal diseases, we should know very well. The age of the patient is very important, yes, because age is a very important and natural cross-linker. So a young patient undergoing refractive surgery is predisposed to ectasia much more than an elder patient. So if our patients are less than 25, we should always be careful. This is, of course, given very well by Dr. Randleman in his score. Thirdly, sex of the patient. Many I would say many papers say that yes, males are a bit more predisposed, but yes, females should also be warned that after pregnancy they can have a chance of increase in ectasia. So patients should be warned about that. Occupation of the patient. There are certain patients who are working in dusty environments, so they will tend to have more allergic reaction, and then they tend to rub their eyes more often. Stability of refraction is very important. We want to wait for at least 6 months prior to our surgeries. Expectations, setting the right expectations is very important. The patient and the doctor should be on the same page vis-a-vis the expectation that the patient has, whether and what timeline we are looking at for visual recovery. And lastly, and not least important, that is general and the ocular health. General health, if the patient is on any systemic medication which can ultimately change our refraction and also change our biomechanics. There are some absolute general health contraindications, that is an autoimmune disease like arthritis or an SLE or a thyroid disease, for which the patient might be on treatment, which can affect our ocular surface also. Immune suppression, HIV or any immune suppression drugs, we should also know about that, and they are absolute contraindications. Pregnancy, yes, pregnancy and lactation, we want to wait at least 6 months after lactation has stopped. And if the patient is on systemic steroids, then we know that yes, the healing can be altered. Some relative general health contraindications could be tricyclics or lithium-based medications. If patient is on such a medication, yes, the patient could have borderline personality issues. Then yes, there could be a mismatch between the patient and the surgeon's expectations for results. Diabetes, though diabetics are also cross-linked, but yes, they can have more changes on the epithelium, so we can have ocular surface disorders, and the patient's refraction might be varying, and the patient can also have an early cataract. So these things must be considered. Active atopy, any patient who has an active atopy would most probably be on systemic or topical steroids, so that is something very important. Epilepsy, if the patient is on epilepsy medication. History of frequent falling, and hepatitis B and C, which could be a potential risk to the surgical staff. Absolute ocular health contraindications could be diabetic retinopathy, glaucoma, corneal dystrophies like keratoconus. Of course, we search for keratoconus prior to our refractive surgeries. History of any ocular inflammatory disorders, hepatic ocular disease which might reactivate after our surgery. Sjogren syndrome can get accentuated. Fuchs endothelial dystrophy, some studies say that yes, because of the endothelial irregularities, we can have flap instability and the flap might not stick very well. Unstable refractive errors and clinically significant cataracts. Some relative ocular health indications, contraindications like a dry eye, blepharitis, nystagmus, and squint. The ophthalmic examination should include all these, but is not exhaustive list. But yes, we should have the UCVA and BCVA measured. The refraction should be done, manifest and cycloplegic. For symmetry for spectacles to see the stability of the power. Ocular dominance should be tested for, especially in the pre-presbyopic age groups, because we do require to see which eye is dominant so that we can plan. Tonometry, yes, to see the pressures. Tear film assessment, anterior eye examinations, dilated fundoscopy to rule out any problems in the retina. Pachymetry, yes, part of our clinical workup. Specular microscopy and orbit configuration, because orbit configuration is very important because we can have problems in docking the patient. So now coming on to the topography and tomography. So this is of course a pentacam. On the top left we can see that these are the patient identifying features. Yeah. The patient identifying features are on the top left. Then we have the corneal front and the back of the corneal measurements. That is, we have the keratometry in terms of diopters as well as millimeters, and also on the back. And very important is the astigmatism, which we should confirm with our spectacle power that the astigmatism is matching. If there is a mismatch, we can be looking at a lenticular or a total eye astigmatism. And also we're looking at the pachymetry, which we'll come to later on. And the front map, you can see this is the actual curvature. Very important. We will look at the type of curvature, whether it is a skewed axis, whether it's a symmetric or an asymmetric bow tie. Then coming on to the pachymetry map, this should be, yes, we know our cornea is thinner in the center and thicker in the periphery. If there is any ectasia, yes, we will see a thinning in that particular part of the cornea. Then elevation maps, which is very, very important. Now that we are looking at tomography, we are also looking at the posterior elevation of the cornea. And since we have started looking at the posterior cornea, the incidence of ectasia has further decreased. Why? Because our ectasia start in the posterior float first and then come on to the anterior. And on the right, you can see this is the Bellin-Ambrosi enhanced ectasia map. You can see that this is the first 4 maps, 1, 2, 3, 4. These maps are the front and the back with the best fit sphere. So if you compare our cornea with the best fit sphere, if our cornea is raising at portions above the best fit spheres, we will have some elevation points. And if this manifests into the difference map, yes, the chances of ectasia are higher. So like I said, this is the quality specification, whether the quality of the pentacam is fine or not. Then coming on to the center of the pupil, this is the pachymetry map. We have to see in a perfectly spherical, I would say, not a spherical, but yes, if we have a perfect cornea, all the points should be coinciding, but they are not. So in case you have this is the pachymetry at the center of the pupil and the pachymetry at the apex and the thinnest point. So if we do have a mismatch between the apex of the pachymetry and the thinnest location, that means that we are looking at a displaced thinnest point of the cornea, which could be an early sign of ectasia. Then also we have the we show the different ICs showing the corneal volume, the anterior chamber volume, and the AC depth, which can give us a very good indicator whether the patient is fit for an phakic IOL or not. So a Kmax less than 48 is very important. If you're looking at readings above 48, we are looking at red flags. Then also difference between the Kmax and K2 of more than 1 diopter is a red flag again. So this is the sagittal map. We can see this is a symmetric bow tie giving us the steep axis and the flat axis, and the 2 opposing points on the 5 millimeter circle. We can see this is the OD, the right eye, and the temporal and the nasal part of the cornea. Information we can have on the curvature map: the flat K, the steep K, the mean K, and the K max. Also the corneal apex and the pupillary center. and the pattern we have to recognize whether if there is an inferior superior asymmetry or a superior inferior asymmetry. So this is a perfectly symmetric bow tie showing a with the rule astigmatism, and this is the steep axis. Similarly, you can see this is an I would say a symmetric bow tie with against the rule astigmatism, and this is an oblique astigmatism showing the steep axis. Skewing of more than 30 degrees is described as a significant abnormality, and should be a red flag for a pre-LVC workup. There are some abnormal maps on the curvature which we have to look out for. This is a symmetric bow tie but with a skew of more than 22 degrees, which is significant. And also this is a asymmetric bow tie. This is also an asymmetric bow tie. So this is a skewing of the axis more than 22 degrees. This is superior to inferior asymmetry of more than 2.5 diopters, and this is inferior to superior asymmetry of more than 1.5 diopters. All of these are, of course, since we have an inferior steeping, that is the threshold for us to expect an ectasia is much lower. These are some abnormal patterns. This is a junction or a vertical D, or a smiling face ectasia, a vortex, or a crab claw showing a PMCD. So the elevation and the elevation subtraction maps, like I told you, if we are comparing the corneal surface with the best fit sphere, if our corneal surface is jutting out of that best fit sphere, we will have an elevation or a plus point, and if it is below that reference sphere, we will have a negative point. So all the hotter colors are showing an ectasia, red colors, and all the cooler colors are showing points which are below the reference line. So the elevation map with the best fit, like I described, this is the symmetric bow tie. So there are certain points which we have to consider for the anterior and the posterior elevation. In the anterior elevation, the cutoffs for a myopic is about 8 diopters, and in posterior it is 18. So it is 8 and 18 for myopic, and 7 and 28 for hyperopic. Pachymetric landmarks, corneal apex, the thinnest location, two opposing points. So we have to look at the, like I said, in a perfect cornea, all these points will be coinciding, but of course, not all corneas are perfect, but we have to look at the pathological corneas where we will have more difference between those points. So this is the difference between on the 5 millimeter circle between the inferior and superior, and the thinnest location and the center of the cornea. So very important points: difference between the pachymetry of the thinnest location and corneal apex should be less than 10 microns. More than 10 could be a red flag. Abnormal thinnest point of more than 470 in normal topography or less than 500 in abnormal. And difference in the inter-eye thickness of less than 30 microns should be there. So inferior displacement of y coordinate is very sensitive. If we have inferior displacement of the y coordinate showing that the ectasia or the thinnest point is far away from the center of the center of the apex of the cornea, that shows a displacement and is a red flag. So this shows this is the center and this is the displacement. Okay. So enhanced ectasia skinning includes a Berin-Ambrosio map, which we have discussed, a corneal thickness spatial profile, and a percentage thickness increase. This shows that yes, there is a corneal thickness spatial profile and the percentage thickness increase. How the percentage or how the cornea is increasing in thickness from the center to the periphery. If this is outside the two standard deviation points, the chance of ectasia are higher. Early detection of subtle changes could be corneal biomechanics, epithelial thickness spatial profile, and Bowman's membrane thickness. So yes, corneal biomechanics has come into the picture recently, but it is very important. If we do if we look at the corvus, we do have a bad D from the pentacam, and we have the TBI, that is the CBI, that is the corneal biomechanical index. But when we fuse together, we have the TBI showing the biomechanical strength of the cornea. This is the epithelial mapping showing us any irregularities. So we should have a percentage thickness alteration ablation less than 40%. More than that could be a chance of ectasia. And of course, now we have on the horizon artificial intelligence. So that could give us a lot of information and tell us much beforehand if there's a chance of ectasia. Thank you. I'm sorry, I can't take questions.
Thank you, Dr. Raghav. Since Dr. Raghav has another commitment, if somebody has any question, so he can answer that right now. Otherwise, we can have questions by the end of the IC. Okay, so there's one more change. Dr. Vishal Jhanji is here and he also has another commitment. So may I invite him to speak on collagen cross-linking for post-LASIK ectasia. It's a keynote address by Dr. Vishal Jhanji.
Thank you so much. I apologize for this. It's funny. Despite so many advancements, we still have not figured out how one person can be in more than one spot at the same time. Hopefully, by next meeting, we'll do that. Okay. So I'll be presenting on post-refractive surgery ectasia. I did notice that there is another speaker in this session who's going to speak on the same topic. So we'll try and not, come too much in each other's way. I don't have any financial disclosures relevant to this topic. Just briefly, the incidence of post-LASIK ectasia is low. So 0.04 to 0.6%. But we don't know whether that is low or it's underreported. Folks who work in tertiary care hospitals, they probably would end up seeing more patients. Folks who live in areas that had more RK patients or LASIK patients with the microkeratomes that used to be 200 microns, they'll see ectasia. About 50% of cases, they present within 1 year. It's, of course, a devastating complication. You started with a patient who was 20/20, is not 20/20 anymore. LASIK is still most common, PRK, very few case reports, but it can still happen. SMILE, we have a few case reports, but we still have to wait and watch. We should probably give a good 10 years and enough cases before we start seeing any complications of that sort. Interestingly, post-LASIK ectasia is similar to keratoconus histopathologically. There are breaks in Bowman's membrane. There's slippage in the interfibrillar lamella of the cornea, and there are interlamellar clefts that can be large. Risk factors, the number one risk factor is abnormal corneal topography. So as the previous speaker very nicely and eloquently told you, if you see red flags, it's an elective procedure, let go of the patient, don't do it. Other lesser risk factors, less prominent risk factors are younger age, residual stromal bed thickness, which is really less than what you want it to be. And we have this PTA, percentage tissue alteration software that was described ages ago by Rendelman. High myopia or thickness, less thickness, residual bed thickness, they're pretty much the same. Enhancements are one risk factor that are sort of undermined. So when you see patients with unilateral ectasia who had surgery 20 years ago, ask them again if they had any touch-up procedures in that eye. And most likely they'll tell you, oh yeah, this eye they had to go back in and do some more laser. So as I said, asymmetry in corneal topography is the number one risk factor. You can have chronic eye rubbing, family history of keratoconus. We definitely ask about any family history. If there's a positive family history, you really have to tell the patient that there is a possibility, although you really can't say that it's really going to happen. Unstable refraction sort of goes hand in hand with the young age. Clinical presentation, progressive increase in myopia. That can happen with cataract as well, so you got to be careful. It might not be post-LASIK ectasia. You can have irregular astigmatism, loss of CDVA. This is really important. The most important thing is you see progressive asymmetric inferior steepening of the cornea, and you do see corneal aberrations, which makes our lives a little easier because we have a way to measure both these qualities easily on Pentacam, other corneal topographers, and things as such. I just want to let you know, the range of the disease is quite a bit. This is a patient who presented with mild astigmatism and blurriness of vision in one eye, and the other eye was normal. And when I did a Pentacam, you basically saw ectasia. And patient was really surprised, and he had no idea what ectasia is. On the other hand, I saw a patient with first presentation with corneal eye drops in post-LASIK ectasia. So this is a patient who was a LASIK flap, has post-LASIK ectasia in both eyes, and this is her first presentation. So presenting with eye drops. So that's a range of presentation sometimes. The patient did well just with the observation and medical management. So you really can't be vigilant enough. This is a patient who is a physician. 2008, he had blurriness of vision, was diagnosed with ectasia. This is 2008, United States of America. Cross-linking was still not approved. Good vision, patient opted to observe. This eye had a touch-up and an enhancement. Other eye was normal. Fast forward 2 years, there was some increase in steepening. Patient still wanted to observe. Still 2010, he was asked to go to Canada. That had cross-linking. Another 2 years, more steepening, more reduction in CDVA. Another 4 years, the patient was still wanted to observe. In 2019, where we actually told the patient that you're going to lose your corneal thickness if you wait more. And that's when the patient decided to have cross-linking. So you see, if you follow these patients serially, and this patient, sorry, I should have mentioned that the birthday is 1955. So all the population-based studies that show that keratoconus will slow down or possibly stop progressing when you touch 40 or so, that doesn't stand true for post-refractive surgery ectasia. Patient born in 1955 was followed from 2008 to 2019 and had continued progression. So that tells us that when you see these patients, you can tell them that you will most likely need an intervention. Another patient, 68 years old, LASIK done in 1999, progressive worsening, had bilateral pseudophakia, YAC cap was done, treated for dry eyes, lid tightening was done. Finally, it was sent to us because the patient was not seeing better. We did a pentacam and we saw post-LASIK ectasia. This is a 68-year-old patient. So really, you can see these patients even later in life. We did a contact lens trial. The visual acuity improved to 20/30. The patient was very happy. But 10 months later, the patient presented with progression. Again, 68 years old. So ultimately, we performed a cross-linking. Management options for for post-LASIK ectasia are contact lenses. You need to have very good contact lens person working in your clinic, and patient has to be motivated. Cost is a factor, but you can avoid surgery in many patients. Collagen cross-linking, as I'll discuss briefly, and of course, for advanced cases, you can do a transplant. Briefly, advantages, as I mentioned, is an excellent contact lens fitting is an excellent non-surgical option. It does not preclude any further surgery in future. Of course, you need an expert, and it's usually expensive. And basically, there are so many contact lenses that are available within India and outside of India that no patient basically exists that cannot be fitted. No cone exists that cannot be fitted because we have customized contact lenses. Collagen cross-linking. I just came from a session where collagen cross-linking was discussed for post-LASIK ectasia. Pretty sure everybody knows we remove the epithelium. We soak the cornea with riboflavin, use UV light for 30 minutes, put a bandage contact lens, and cross-linking is done. There is a clear shift in corneal biomechanics. That is what you're looking for in cross-linking. Relatively easier procedure, relatively inexpensive compared to contact lenses, and transplant follow-ups are not needed. I'm not going to discuss the types of cross-linking. We still try and do conventional cross-linking, the original Dresden protocol, where you take off the epithelium, soak the cornea for 30 minutes, and use UV light for 30 minutes. You can change your protocol, use accelerated cross-linking. You can leave the epi on if you want to, but we still do conventional epithelium off. Example, 52-year-old patient. You see, all patients that I presented are more than 50 or so. LASIK done in 2003, approximate myopia was high, minus 975. Visual acuity at presentation was 20/70 and 20/30. Saw this patient, told them they have likely ectasia. So we did the cross-linking. I always tell my fellows, you have to mind the flap. You really can't be careless with the flap. It might come off when you're removing the epithelium. That's why we use alcohol delamination. We use 20% alcohol, and the epithelium comes off very easily. And you can expect diffuse lamellar keratitis even after so many years. So you have to use steroids. You can use fluoromethanol or methanol or lodepride, but you don't need to use prednisolone really. So this is pre-cross-linking, and you see even 3 months down the line, you can see some flattening in this patient after cross-linking. So basically, at 6 weeks, the acuity was 20/70. It changed to 20/60. In 3 months, 20/50. 6 months, 20/50. And with refraction, not contact lenses, the patient could be improved to 20/20. Last option, corneal transplantation. Nowadays, everybody tries to avoid that if you can. Risk of rejection, infection, glaucoma. And these patients usually need a very large graft, which can be really challenging unless you have access to femtosecond assisted dissection. This is one of my mentors, Dr. Vajpayee, who's in Australia now. He published this 2008 So basically, you do a mushroom keratoplasty, lamellar though, and you tuck in the edges of the graft into the host bed. You can do this easily manually if you have access to femtosecond platform. Of course, it's going to be easier, it's going to save time, but it leads to massive flattening of the cone, and patients uncorrected visual acuity improves as well, and you can fit a contact lens or even give glasses. I'm not going to discuss this, but I can tell you my experience with the combining cross-linking with refractive procedures has not been great. We actually published that these patients will lose vision at least a line for the first few months. So definitive evidence is still lacking just because of lack of randomized control trials and long-term follow-up. So to conclude, post-refractive ectasia is a rare complication today. Corneal tomography, it enables us to as you saw in the examples, unless you don't expect it and you don't do a corneal tomography, you're not going to find it. Management depends on the stage of the ectasia. Contact lens fitting is definitely always an option before surgery. If the patient is motivated, cross-linking might help to slow down the progression, and the corneal transplantation needs special techniques. Thank you very much for your attention.
Thank you, Dr. Jhanji. That was wonderful. I have a question if you have time.
Yes.
So, what is your experience with PRK with C3R when a patient is diagnosed with keratoconus?
So no, we don't do refractive procedures in diagnosed patients of keratoconus. You can try and do a refractive procedure in a borderline patient with corneal tomography. I've never performed refractive procedure of any kind in a patient who's known to have keratoconus. I'm not for it because we don't have long-term studies.
Yes, because these days refractive conferences are all highlights with the refractive procedures in keratoconus and ectatic patient. And I thought maybe if somebody has more, but the evidence are lacking in literature, of course. So I'm also not doing it, but a lot of people are advising these procedures to keratoconus patients as well.
Yeah. So two things to that. One, of course, it's entirely dependent on the chairperson, the moderators, and the audience to ask questions, like you did right now. And I told you frankly that I don't do those. The second thing is, you might get lucky, for the first few patients. So have you ever met anyone who had LASIK in 1990s? They're still very happy. So most of the patients, they're very, very happy after LASIK. And they had LASIK with microkeratome when we used to cut flaps close to 200 microns. It's really shocking that we used to do that. You see patients who had RK. I personally know people who had RK. They're very happy. They're never going to say anything against RK. So you do get lucky many times. But when you see unhappy patients in tertiary care centers, then you realize the amount of complications that can be associated, unfortunately, with some of these procedures. So it's better to play safe. One of my mentors always had the mother rule. The rule is if you can do a procedure on your mother, you can go ahead and do it on your patient. I still remember that.
Touche.
Thank you very much.
So one question.
Yes, sorry, I apologize.
Have you ever noticed that the effect of cross-linking in post-LASIK ectasia is much more than what is seen in keratoconus?
I have noticed that. We have not been able to publish that. We have only about 50 cases so far. But I agree with you, and that encourages us to convince the patient for cross-linking. And post-LASIK ectasia in pediatric cases, we don't wait for too long to document progression.
So at the first diagnosis, we should go ahead and do.
Well, at the first diagnosis, you can recommend cross-linking. Yes. They're not going to progress in 2 months. You can still wait for 4 months. It's always good to show some progression. It's not going to change your management or the outcome if a patient progresses by another half a diopter when you see them again in 3 to 4 months.
Yes. Thank you so much.
Those primary keratoconus patients, any experience with the topo-guided PRK smoothing first and then doing C3R on top of it?
No, I don't have any experience. As I said, I really don't know what we are achieving with smoothing. So primary keratoconus, it all depends on the stage. If you are looking at a patient who has minus 1.5 diopters of myopia and minus 2 diopters of astigmatism at 68, just made up a hypothetical number. Corneal thickness is 450 microns. So that is a borderline case. It's not keratoconus as of yet. you can stage and the other eye is normal. Okay, so for this patient, you might think about combining a procedure depending on how keen that patient is.
Yeah, suppose there's a loss of best corrected.
Mhm.
Suppose you are at 618, maybe 624, and you want to improve the best corrected and maybe help the patient not to be on contact lenses, maybe get rid of contact lenses. So what we are doing is that all those cases whose best corrected vision is not improving to 6/6, so we are doing a primary topo guided PRK. So we're trying to smoothen the surface and then doing a C3R on top of it. And we are seeing that the best corrected is almost increasing by 2 lines.
Okay, so I encourage you to publish and present your results,
Yeah,
that
already
especially the long-term follow-up. So you have to agree, though, with topo-guided PRK, sometimes the refraction can change drastically. I don't know what your experience was. And then you end up basically not correcting too much for refractive error. So the patient would still need glasses or contact lenses.
Yes, of course, with glasses. But
Yeah.
what we are only trying to do is just get him maybe off contact lenses,
Uh-huh.
and so that he has more options to maybe have a better quality vision. Plus, also I wanted to ask, any experience with intacs in post LASIK ectasia?
Sorry, let's go back to that case. So if you are smoothening and the patient still needs cross-linking and glasses or contact lenses, what is the advantage of that
That
smoothening?
sometimes you can maybe take him off hard contact lenses.
Yeah, but hard contact lenses, most patients don't use RGPs nowadays.
Yeah,
There are
yeah.
mini-scale lenses that are as comfortable as soft lenses. I'm yet to see patients with keratoconus who do very well with soft lenses. I mean, there are a few, but not many. Young patients do well. So ultimately, everybody needs a customized contact lens. So that's the reason we try and not take away any tissue in a keratoconus patient. So we don't have evidence. I'm sorry, we're taking so much time. So recurrence of keratoconus or ectasia is supposed to happen in 7 to 10 years. The collagen in the cornea sort of regenerates or reprograms itself, and on average, it's 7 years or so. So we don't know how long. If you take some tissue from a keratoconic patient doing topo-guided PRK for smoothing, we don't know what you are doing to these patients in terms of corneal thickness and their risk for progression again. So you really have to follow them up, ideally for at least 5 years, if not 7. Intacs, you can do intacs if you have a really bad cone. But again, the point is, if you're going to fit a contact lens, and intacs is going to make the contact lens fitting better, then I would go for intacs. Otherwise, there's no point doing an additional procedure.
Good, because what happens is that usually in our practice we see that people are not very motivated to wear those hard lenses, and usually they are looking for a solution. That is because when we counsel them initially and when we give them an option of a basic primary C3R versus combining it with a topo guided PRK with C3R and reducing the dependence on contact lenses maybe in future, so they're very convinced listening. So of course the patient selection is important. You should
Yeah.
have a sufficient thickness, and you have to see that you're not over ablating more
Sure.
than 40 microns whenever you are smoothing.
Yeah,
Yes, then-
definitely. And again, I tell you that 40 microns is just a number that came from New York, and nobody looked at the validity of that number. I would if given a choice, I would rather do intacs. But you're still an additive technology, than take away any tissue at all. Those are the only papers that are published. We still have follow-ups are pretty short. All right, sorry we took more time. Thank you very much.
Thank you, sir.
So now we have our next speaker, our chief instructor, Dr. Tulika Chauhan. She will be presenting on the borderline cornea, when to proceed.
क्या करना है इसमें कुछ? Yeah, so it is there. Okay, are we there? A good afternoon to everyone. I'm Dr. Tulika, and I'm going to present the next talk of this IC, when a ride goes wrong. So, when there's a borderline cornea, when we should proceed. I will try to cover a few points from my clinical practice, And you might have different opinion, so we can discuss that what should be the better thing to be done for the patient. I will tell you that what I have done for the patient. So we have discussed this already, that corneal ectasia is a sight-threatening complication of keratorefractive surgery, which is characterized by progressive steepening and thinning of the cornea. Why it is a problem? Because of irregular stigmatism, loss of BCVA. It can present date 2 years after the procedure. And the prevalence is theoretically low, estimated to be 0.04 to 0.6%, as Dr. Jhanji already told in his last talk. So the question is, are we underestimating it or are we understating the problem? The clinical significance, the post-LASIK ectasia is clinically important from 2 aspects. First of all, the condition is preventable, and most LASIK patients are young adults in whom the burden of the condition is greater. So understanding a safe threshold, what is borderline cornea? How thin is too thin? And how thick the cornea be to maintain the structural integrity? And how deep can the surgeon go? So these are the questions which we are searching in our day-to-day practice. And there is no number in the literature which can give us answer. So why do some patients with abnormal topographies not develop ectasia following keratorefractive surgeries, while some patients with normal-looking eyes do? Are thin corneas an independent risk factor for post-LASIK ectasia? The answer is corneal thickness alone is not a measure of corneal inherent structural stability. Crosslink corneas are stronger, stiffer, and more compact, that is thin. Keratoconus can be seen even in the eyes with thick corneas. So the pachymetry is not the only answer for this. Red flags are shape and size. We deal with curvature, diameter of the cornea, the pachymetry, of course, comorbidities like autoimmune disorders, scarred cornea, for example, post-RK, post-viral keratitis. What determines successful refractive outcome? We all know, we all do this. We do maximum for the patient, right? We do patient selection, a careful history, detailed informed consent about risk and benefits, meticulous preoperative testing. So these are the extensive examination which we all do in our day-to-day practice when we are doing refractive surgeries. There are relevant factors in refractive surgery screening, and these are intrinsic biochemical properties, for example, tomography, and the age, which we cannot change. So these factors, along with amount of refractive error, are the basis of most of the ectasia scoring system also, because these are intrinsic factors, and we have to consider these factors. There are alterable biochemical properties, for example, percentage tissue alter, which was extensively covered, amount of tissue altered by the keratorefractive procedure, and the residual stromal bed, that's remaining load-bearing tissue post-refractive procedure. Age is very important, as we all, as they mentioned, like young age, they have higher risk of ectasia, higher risk of unstable refraction, higher risk of non-compliance. And the older patient, the presbyopia may not allow glasses independence, may have to consider monovision. Lenticular status may make keratorefractive surgery moot, and often have other ocular comorbidities. So we'll discuss about the residual stromal bed. So what is the magic number? So I'm sure most of us are doing refractive surgery here, but is there a magic number what we are following? I don't think so. That's the answer to it. Yeah, because residual stromal bed should not be more than, should not leave it more than 50% of original corneal thickness, since the structural support for the cornea has shown to be reside in the anterior cornea. For example, if the pre-surgery pachymetry is 546, then post-ablation RSB should be more than 273. It is recommended. Nobody has all the evidence to prove this, but that is the maximum thing which literatures tell us. Each surgeon must develop his own safety limit for the RSB, but this should not be less than 300 micron, though literature says that RSB should be between 250 to 300 micron. A lot of people follow these days that your RSB should be more than 300. Percentage altered, how preoperative corneal thickness combined with excimer laser ablation translates into post-operative corneal biomechanics. The PTA matrix representing the percentage of anterior corneal tissue that is modified during refractive surgery. The PTA takes into account the integrated relationship between preoperative corneal thickness, ablation depth, flap thickness, and the final RSB. So this is a calculation we all know we are following in a day-to-day clinic, and it's an independent indicator of post-operative corneal ectasia according to the literature. PTA more than 40% is negative prognostic indicator, and yeah. So we'll discuss some clinical scenario where I was confused, and I was confused that which surgery to be done for the patient. So there's a 32-year-old woman present for LASIK consultation with hopes of being less dependent on her glasses. She does not wear contact lenses. The external examination reveals excellent exposure with corneal diameter of 10 millimeter, anterior segment evaluation normal, fundus normal. This is a refractive screening for the patient, and yeah, we can see she has a moderate myopic astigmatism. My challenges were a relatively steep curvature around 46 and 47, small corneal diameter around 10 millimeter, though the cornea was normal, thin pachymetry 504 to 507 micron, and the large pupil size. So the challenge was in shape, size, and the thickness. So all the three factors were challenging for me to take decision. So when I calculated, my RSB was 326 micron, 333 micron, which is more than 50% of corneal thickness. My PTA was 35.2% and 34.2%, which is less than 40%, of course. So the surgical option I was looking for keratofractive surgery and the lens procedure. So microkeratome LASIK, what were my challenges in this case? So the flap diameter is dependent on corneal curvature, and the flap must be large enough to accommodate the large treatment zone, yet not so large that it extends into the limbus. Slight flap decentration, there is significant risk of limbal invasion and hemorrhage. In femtosecond LASIK and SMILE, the flap diameter is independent of corneal curvature, and the diameter is a preset diameter. So the limitation is centration is a concern. Flap edges close to limbus, limbal bleeding can happen. Then the PRK is my another option, in which no flap related risk, a large zone with the added blend, and the excellent centration should not be difficult to achieve. Limitation, in higher number we can get regression, haze, and the last option was a faking implant, which is the cost is a factor of course, and the intraocular complications. So patient opted for PRK, and there's a discussion about haze and regression, and we have good RSP for the patient 434 and 439. So the take-home message is recognize the special challenges posted by the patient with microcornea. Surface ablation remains an important keratorefractive option in selected cases. The femtosecond laser is safe than microkeratome in patients with small, steep cornea because it offers more control over the flap diameter. These are my things, but you can always add like what are your challenges and what you think the right option for the patient should be. The another clinical scenario which I want to discuss here is a 25-year-old woman wearing RGP for 11 years. She tolerates a contact lens for 14 to 16 hours daily. The lens power has not changed in last 2 years. She was asked to leave her contact lens out before the examination, but she didn't have any glasses to wear, so wore the contact lens up to the time of her examination. Microscopic examination reveals 1 to 2 millimeter superficial vascularization in both corneas, consistent with her long-term contact lens wear. Corneal diameters are 11 millimeter horizontally. The rest of her examination is normal. The eyelid fissures appear adequate for the microkeratome suction ring. This is her refractive screening. She has quite a good high myopia, and on topography we find there's a mild inferior steepening in both eyes correspond to keratometry and refraction. Posterior elevations normal maps. So my challenges were, will there be adequate stromal bed for laser ablation to correct this amount of myopia and astigmatism? With spherical equivalent of -10 and 9.5, a conventional laser procedure can be estimated to be 120 micron ablation and 114 according to the refractive error to provide the complete correction. RSB is 285, 293, which is more than 50% of the CCT. And the PTA is 44.6 and 43.3%, which is more than 40. The corneal topography shows inferior steepening along with somewhat high K readings and slightly thin central pachymetry. Calls for critical evaluation for subclinical keratoconus. Is it contact lens warpage or molding? It can be. So we ask patient for the contact lens free period. Topography shows nearly complete resolution of inferior steepening and no inferior thinning on pachymetry. Slit lamp examination was unchanged. So the manifest refraction, what you can see here is the thing after at least 6 weeks of contact lens free period for this patient. And then the concern was in keratorefractive procedure, if we choose keratorefractive procedures, then the borderline stromal thickness for laser vision correction, PTA more than 40%, future enhancement not possible without enough corneal stroma. The treatment plan was phakic lens implant for this patient. We did toric implantable Collamer lenses, and the vision is fine. Patient has no vision problem. She's in the follow-up. The take-home message, the differentiation of subclinical keratoconus from contact lens-induced corneal warpage is important for both accurate surgical correction and safety. Phakic IOL implantation is a good option to discuss with patients who have suggestion of FFKC on their preoperative topography. Phakic IOL procedures equivalent or superior vision for the patient with inadequate or borderline stromal thickness for the laser vision connection. The last scenario which I want to discuss with you is a 30-year-old Asian woman who was interested in refractive surgery. She had worn contact lens for 10 years and had been out for 3 weeks. The pulmonary fissure was small and the lids were somewhat tight. The corneal diameter was 11 and IOP was 12. The slit lamp examination was normal and fundus was normal. This is a refractive screening of the patient, and I'll show the topography in the next page. Okay. So my challenges in this patient were the topography. I think it's not very clear. I'll show it. Relatively thin pachymetry, then increased risk of night vision symptoms with high astigmatism. Pachymetry maps reveals the thinnest portion of the cornea to be displaced inferior-temporal in the right eye and slightly displaced inferior-temporal in the left eye. So if you see this, so there's a little displacement. So it's one factor which is giving me a red flag. So examination in favor. BCVA is more than 20/20, patient for 25 years, stable refraction for 2 years, normal curvature and elevation maps, normal bad score. RSB is 353, 343, which is more than 50% of CCT, and the PTA is 29.6 and 32.1%. So the pachymetry curves follow the mean and standard deviation curve, indicating that corneal pachymetry increases appropriately as one progresses from thinnest portion of the cornea to the periphery. So the conclusion is, pachymetry finding alone are not sufficient for the surgeon to reject the patient as a candidate for the refractive surgery. Surgical plan, patient opted for PRK, and we discussed the risk of haze and the need of steroid for post-op. So thin pachymetry, tight lid, small pulmonary fissure, small corneal diameter, PRK seem to be a better option than LASIK sometimes. If you have to do microkeratom LASIK, then PRK is better option in such cases. So post-op patient was 20/20 plus, and this is the refraction of the patient. So here the careful analysis of corneal topography, power elevation, and thickness is especially important in highly astigmatic patient to rule out signs of pre-existing ectasia. Highly astigmatic patients should be presented with realistic vision expectations and warned about possible night vision problems. Successful correction of high astigmatism has potential to improve near as well as distance vision even in the young patient. So clinician must never rely solely on one measurement or data point in determining the patient's suitability for corneal refractive surgery or ectasia risk. Nevertheless, with improved screening protocols, enhanced understanding of corneal biomechanics, and judicious application of patient selection criteria, we can strive to reduce the incidence of post-operative ectasia as much as possible. So crucial is to understand, recognize, and accept the risk factor critical toward achieving a significant reduction in occurrence of this adverse effect. Thank you very much. This is my time. And we can take question by the end of ICUs as well. So if you want, I can just invite another speaker. Kanika?
Thank you so much, ma'am. So we can invite our next speaker, Dr. Kanika Bharadwaj. She will be speaking on the third wheel extra procedures.
A very good afternoon to one and all. So in keeping with the theme of today's instruction course, I would be just introducing the extra procedures to the audience. And I would like to disclaim here that I'm not either in favor nor against these procedures. So what are the extra procedures? In a refractive surgery practice, the most dreaded complication is the post-refractive surgery ectasia. And hence, while most of them are refractive surgeries are very safe and effective, we do have certain limitations. PRK, LASIK, and SMILE are the most common things in our armamentarium these days, and they're still not immune to complications. There could be regression after the post-op period, or there could be iatrogenic induction of ectasia. Biomechanical stability is the concept behind all these problems, and we do know that all these procedures are subtractive procedures, and thus they do take away from the cornea and its strength. So like in PRK, there is an injury to Bowman's membrane, and in LASIK and SMILE, there are creation of vertical delamination cuts, which again reduce the strength. It has been noticed in multiple studies that corneal weakening after laser vision correction is definitely there. There is about 14 to 33% corneal weakening just by increasing the flap thickness. So we can see here that 180 micron flap will have more weakening as compared to an 80 micron flap. Now coming to extra procedures, what is extra? Extra means we are doing a simultaneous corneal collagen cross-linking along with the refractive surgery. Now, corneal collagen cross-linking has been long in vogue for corneas that have been diagnosed as having keratoconus or even ectasias. So this therapy is proposed as a prophylactic or an adjunct to corneal refractive procedure. So at the one hand, where we are deleting a tissue, we are also providing some additional biomechanical strength to the treated cornea. So this is to prevent any future ectasia, especially in borderline corneas. So the procedure involves conducting the refractive surgery followed by an accelerated protocol of the corneal collagen cross-linking. So extra procedure can be combined with PRK, LASIK and SMILE, all three. Apart from the biomechanical advantage, simultaneous cross-linking can also lead to less epithelial thickness increase post-operative, which is also implicated in the regression post-operative period. So this picture shows a control cornea which has not been cross-linked. On the right, we can see a cornea which has been cross-linked. So we can definitely see the integrity, the strength and the holding of the tissue is better after cross-linking. So it restores strength, it improves the flap bed adherence and also gives a better tensile strength. It also reduces regression and risk of ectasia. Now, is it suitable for everyone? The answer is we don't know yet, but still there are a few indications where we should definitely consider giving this as an option to our patients. So it could be the thinner corneas. There's no arbitrary number, but usually people take it to be less than 500 microns. High myopia, more than 6 diopters, where we need more of tissue subtraction, family history of keratoconus, or any topographic asymmetry noticed on the tomography maps. If there is difference in astigmatism between the two eyes more than a 0.57 diopters, and young patients who can have unstable refractive errors, hyperopes, as again because it prevents regression. There's also a paper in Indian Journal of Ophthalmology similarly citing various criteria how to decide upon whether a patient has to be taken up with for extra procedures or a refractive surgery alone. So coming to the types, PRK extra, very commonly performed if preferred amongst the extra procedures. It is for patients with borderline corneal thickness where it might not be very safe to go ahead and perform a flap surgery or a SMILE surgery. Corneal collagen cross-linking is performed after performing the PRK, or enhancement is needed, or when the surgeon wants to strengthen the thin cornea which is noted preoperatively, or if there's any asymmetry, if there is against the rule astigmatism or even steeper looking corneas. So the procedure involves similar protocol. Epithelial debridement can be done by any of the methods like alcohol delamination or scraping, following which the excimer laser treatment is fired, then is soaked with isoosmolar riboflavin. Now here the dye that we used is mostly in vehicle either as HPMC or saline. We do not use dextran based dyes here. And it is soaked for about 90 seconds, followed by a UVA exposure at 30 milliwatt per centimeter square for 90 seconds. So the total energy that is delivered in this procedure is half of the conventional dose, which is 2.7 joules per centimeter square. At the end of the procedure, mitomycin C is applied and then washed and BCL is applied. Now what is next? Next is the LASIK extra. So what are the mechanics here? So after the excimer laser has been used to reshape the cornea during a LASIK procedure, a small amount of specially prepared dye, such as one by the name of Vibex, which contains again saline, not the dextran, is applied for 90 seconds, and the protocol similar to the PRK1 is followed. So the images here show the protocol being followed. Now important here is to not get the flap in touch with riboflavin dye, so we want to avoid that. There's just a small video of the same. So after creation of the flap and raising the flap, the excimer laser is fired. Now, riboflavin soaking in isoosmolar concentration is done. It is then washed. The flap is repositioned. And then UV exposure is done. So this is just an idea about LASIK extra. Of course, the risks related with the corneal collagen cross-linking such as haze do exist. Safety of LASIK extra, there have been multiple studies. The manufacturer Avedro has also conducted a big study where they included about 52,000 eyes in Japan, and they concluded that overall the vision in patients who underwent extra procedure and who did not undergo extra procedures was similar at the end of procedure. So it has been deemed as a safe and effective procedure. Coming to Smile Extra, Smile is the latest and it is performed as per the standard protocol, that is after delamination of the anterior and posterior laminas, lenticule is extracted. Now the space that is created after lenticule extraction is then filled with 0.25% riboflavin in saline, which is injected and allowed to diffuse for about 60 seconds, after which it is rinsed off, and over this we then go ahead with the UVA radiation in the similar dose that is delivered as per other extra procedures. So this is a video of the Smile Extra, how it is done. So here we see docking and the laser being fired, creating anterior and posterior laminas. Separation. The lenticule is then extracted. Now this is followed by injection of a riboflavin dye. So usually in our center we do it at the same sitting. As soon as the Smile procedure is over, a 60-second soak is given, and after rinsing off the dye, UV exposure is done. So I would like to conclude that corneal collagen cross-linking, which is an already proven procedure to improve the biomechanical strength, can also be used in prophylaxis with refractive surgery procedures in order to give strength to those corneas lying on the borderline limit for refractive correction, or the ones giving us confusion in our clinics. It also works by creating additional chemical bonds between the various proteins and the collagen in the stroma. Both ectasia and regression are supposed to and postulated to occur as a result of biomechanical changes affecting the strength, and hence this procedure theoretically should impart more strength and thus reduce these risks. Comparative studies have shown that combined surgery and simultaneous cross-linking has similar or better efficacies, but long-term studies are still warranted. We also have to know that while performing these procedures, there are still risk of complications such as development of post-operative ectasia even after this procedure, which is possible. Therefore, flapless procedures are preferred, such as PRK and Smile. LASIK, due to the induction of vertical cuts and more tissue subtraction, flap also does not contribute to the strength, so is less preferred if compared. Haze definitely is more in PRK, has to be kept in mind. The flapless surgeries are again better preferred. There is always a risk of over and under correction if there is too much of drying or too much of UV exposure, or there is irregularity in the irradiance. So that also has to be kept in mind. Nevertheless, these procedures are there and are available in our armamentarium. So we should keep them in mind when we are offering refractive surgery to patients, or when we are straight away going and rejecting them. Probably we can give them a chance. If anyone has already started working on publishing data, we would like to read their results. Still, I would say that long-term studies are warranted to deem these procedures as entirely safe. Thank you.
Thank you, Dr. Kanika. That was wonderful coverage of extra procedure. I would like to invite Dr. Dipali Singhal. She's going to speak on diagnosis of post-laser vision correction, which is a very, very important topic, because if you miss that, then it can give you like threatening results. So Dr. Dipali, she's a cornea consultant with Anilai Hospital, Thane. Do you have any questions regarding the last talk? Yeah, please go ahead.
Wonderful session. So one thing, I'm Dr. Swapnali from Hyderabad. So I want to add one thing, that even with all the criteria, if we go back and read the 2008 series by Palicaris, 9 to 10 patients of his series had thickness beyond 500, very good residual bed, and they still ended up with post-LASIK ectasia. So I think the chair time we spend with the patient before a procedure helps us if any untoward even happens after that. And when we have the consent protocol, this point should always be highlighted. I want to put this especially for the budding refractive surgeons.
Yeah.
And another thing is that I think you are going to mention about the Randleman's risk ectasia score in your talk.
Yes.
So I'd be happy to see that, because all through these years, even though there have been a number of ectasia scoring, Randleman's score is still the go-to score for this. So thank you. That's all I wanted to say.
Thank you, doctor. Thank you.
So good afternoon everyone. I would be discussing about post-laser vision correction ectasia, which is still difficult to understand, and this makes it very challenging and interesting as well. So ectasia is a very grave and a serious complication, and no refractive surgeon wants to see this. However, it still can happen and you will have to face it. So early diagnosis and high index of suspicion is very important. It was first described by Siller et al. In 1998 in 3 eyes which were operated for high myopia. The exact incidence is still not known, but it is reported to be 0.02 to 0.1% as of now, which has reduced from 0.6% reported by Palicaris et al. In 2001. So 50% of the patients present within the first year and around 80% within second year. So it is very important to regularly follow up all your cases even till 5 years and even up till a decade. The incidence reported is to be maximum with post-LASIK eyes, that is 0.1%. However, it is much lower with PRK and SMILE, but with SMILE it is still under investigation because long-term studies are not yet published. Recently, Ganesh et al. Has reported post-SMILE ectasia to be 0.15% over a short period of follow-up of 1 year. So various risk factors and red flag signs have been discussed. The most important one is abnormal or borderline tomography to start with. So it is very important to have a low threshold for excluding these cases. There are various scoring systems available. Randleman scoring is the most commonly which is used. However, it has limitations like it does not consider the posterior corneal surface or tomography and even the thinnest pachymetry. So it is also not a foolproof method. Like in this example, it shows that the Randleman ectasia score is 2, but even then the patient developed ectasia. The main factors were thin cornea, which was 483, and the elevation map was tongue-shaped, though the values were normal. So irrespective of how well you screen the patient, ectasia still can happen. A significant percentage of eyes have shown to develop ectasia even without any clinical or tomographic risk factor. So let's say that even after meticulous screening and taking all precautions, we come across such patients. So how will you diagnose it as early as possible? So typically this patient who has gained perfect vision after surgery will come to you with a gradually progressive decrease in both best corrected as well as uncorrected vision, with a gradual increase in myopia as well as astigmatism, along with poor quality of vision such as glare, halos, and distorted vision or ghost images. So keep a very high index of suspicion and always investigate. Do not misdiagnose as regression and retreat, which would worsen the visual outcomes. Also, it is important to rule out dry eye and dysfunctional tear syndrome, which can also lead to poor quality of vision sometimes. So when you investigate further, you can see there can be clinical signs of ectasia, increase in anterior and posterior elevation, the cornea becomes more prolate, and there is an increase in spherical aberration and coma. There is progressive steepening and thinning, but the most important thing to diagnose is the posterior corneal surface steepening. So though there are no standard criteria, Randleman has proposed some factors like as compared to the immediate post-LASIK parameters, change in refraction by 2 diopters, reduce in vision by 2 or more lines, and increase in corneal steepening by 1.5 diopters is significant. So documentation of all findings at every follow-up in a post-refractive surgery patient is very important. So serially document uncorrected as well as best corrected vision, refraction, keratometry values. Look for any abnormal retinoscopy reflex, check for quality of vision. If any patient is complaining of any kind of glare, halos, then please investigate. And whenever you see there is a progressive increase in all these parameters, then it is a sign of ectasia. So the most important investigation is corneal tomography to see the posterior corneal surface, which is first affected in these ectasia patients. Along with this, serial pachymetry and corneal aberrometry can be done. So to confirm ectasia, you look at the posterior corneal surface using the tomography. Any significant change in the posterior surface, like in this case, we can see a localized posterior elevation, is very important. Serial scans are important to see progression, which is often rapid. So first you look at the maximum elevation values within 4 mm zone, and then the enhanced posterior elevation maps. In early ectasia, this will be first affected. However, do not look at the D value or the complete bad map, since it was designed only for the pre-op screening and compares the patients to a normative database. So in early ectasia, very subtle changes like mild increase in posterior elevation and steepening of the anterior surface are seen, and you can detect if you compare it with the immediate post-op maps. So it is important to perform tomography at 1 month post-op also, so that you can compare later. However, in advanced ectasia, there will be findings which are similar to keratoconus. Important predictors in the diagnosis include BCVA, refractive spherical equivalent, highest posterior elevation within 4 mm zone, spherical aberration and coma, and the Q value. So a significant increase in the maximum elevation values, reduction in thinness pachymetry along with a more prolate cornea giving rise to a more negative Q value, along with a significant increase in the keratometry values, Kmax, corneal cylinder, and irregularity indices is significant. Another important finding is that in early ectasia, the location of the steepest point is mostly central if the baseline cornea was normal. However, if the baseline cornea was FFKC, then inferior ectasia is more common. Next, you always see the serial maps and progression displays. You can compare any 2 or 4 maps on tomography. Pre-op and serial post-op scans are important along with the differential maps. Then in the corneal aberrations, there is maximum increase in vertical coma, and spherical aberration negative value also increases, which explains the poor quality of vision. Grading system has also been proposed on the basis of these 5 predictors, which can help to quantify ectasia and monitor the progression. So coming to an example, this is a 21-year-old female with moderate myopia. There was no history of any other ocular or systemic complaint. Refraction was stable, so she underwent LASIK workup. Corneal topography was documented as normal, and all the other parameters like PTA, RSBT, and the ablation depth, flap thickness were normal, so microkeratome LASIK was done for this patient. However, on follow-up, she presented with diminution of vision at 1 year also. So what do you suspect, ectasia or regression? So now, first of all, a very well documented serial clinical examination is important. You can see that there is a progressive increase in both myopia as well as astigmatism, along with reduction in both UCVA as well as BCVA. Patients started complaining of poor quality since 2 years, like halos, which increased to diplopia at 6 years. So if you again go back and see the pre-op baseline tangential topography, changing the scale and reducing the range, you can see that there is a significant superior steepening with abnormal asymmetry of 3 diopters. And other risk factors include young age, so the total randomized score was 4. And the similar picture was seen in the left eye also. So now you can see that even at 1 year follow-up, there was significant astigmatism along with diminution of vision. So the first step at this time is to evaluate the posterior corneal surface and do a corneal tomography. But in this case, it was done at 2.5 years, and then she was diagnosed at 6 years, and CXL was done at 6 years. So if you see the trend of tangential curvature, then in the central 3 mm zone, there is a progressive steepening and increase in cylinder from 1 to 3.5 diopters. You can see that the color in the central area has changed from blue to green at 2.5 years. And at that time, only posterior surface evaluation should have been done. But then as it progressed at 6 years, the central area even showed more significant steepening with the red color in the central 3 mm. So when pentacam was done at 2.5 years, if you see the posterior surface elevation, there is a clear localized elevation of 13 microns and 19 microns, which increased to 31 and 58 at 6 years. At this time, the patient was diagnosed and treated. So you can also see the comparative maps at 2.5 years. There is a borderline posterior elevation of 17 microns with a progressive steepening, which can be seen in both anterior as well as the posterior surface. And if you see the thickness map, a progressive decrease in thickness can be seen from 461 to 438 microns. Then if you see the abrasion profile as compared to the baseline, even at 1 year post-op, in right eye, a significant increase in vertical and horizontal coma was seen, along with a more negative increase in spherical abrasion, suggesting that ectasia started developing at 1 year only. Whereas in left eye, the abrasions were constant. Then from 2.5 to 6 years, there was a very significant increase in the coma as well as spherical abrasion, which explains the poor quality of vision, which started from 2.5 years. In this progression display also you can see that maximum changes are present in the posterior corneal surface from 2.5 to 6 years in the right eye, and whereas in the left eye there is no significant change till last follow-up. So now if you see carefully at 1 and 2.5 years follow-up, a significant increase in astigmatism along with reduction in UCVA and BCVA with poor quality of vision. On investigating progressive steepening of the anterior surface with increase in keratometry values, corneal cylinder, Kmax, and reduction in pachymetry are all suggestive of ectasia. This is another patient which developed ectasia following SMILE. This is the pre-op tomography, which shows only one borderline risk factor of posterior elevation being 16 microns within 4 millimeter. However, at 1 year post-op, corneal cylinder increased to 1.2 diopters with central steepening and reduction in pachymetry. And at 1.5 years, significant increase in posterior elevation was seen, along with central steepening suggestive of post-SMILE ectasia. This patient was planned for corneal collagen cross-linking. So other modalities which can pick up early ectasia include corneal biomechanics, epithelial profile, and Bowman's membrane thickness. So why we can't explain ectasia with tomography alone? There are other risk factors like biomechanics, subclinical inflammation, eye rubbing, allergy, and pregnancy. This is a wonderful article which explains the pathogenesis of ectasia. This article explains the role of subclinical inflammation. So in post-classic ectasia, they have reported that there is a very high density of dendritic cells as well as poor nerve regeneration, along with increased inflammatory markers in the tear film. This study also shows that there is an increased elevation in the tear levels of MMP9, suggesting a subclinical inflammation. So at last, if you want to differentiate it from regression, in regression, the best corrected visual acuity is within normal limits. The quality of vision is also normal. The corneal aberration profile will also be normal, and the posterior cornea in most of the cases remains stable. Though the most common cause of regression is epithelial hyperplasia, it often presents with anterior corneal steepening. Pachymetry sometimes can increase also, and the main increase in refractive error is due to increase in myopia and not astigmatism. So to conclude, document serial clinical and tomographic findings, never miss subtle changes. Always compare pre-op, immediate post-op, and serial post-op scans. Early diagnosis and early intervention is the key. Rule out ectasia before doing any retreatment, and all ectasias are progressive by nature as compared to keratoconus. So diagnosis is often delayed because routinely we are not doing tomography imaging after every refractive surgery. Do not wait for progression. Early treatment is the key. Thank you.
Thank you, Dr. Dipali. That was wonderful. So now we are going to invite Dr. Yoganki for presenting managing post-laser vision correction ectasia.
Ectasia typically presents with progressive corneal thinning and steepening, usually inferiorly, with loss of best corrected as well as uncorrected visual acuity associated with increased myopia and irregular astigmatism. In cases where the ectasia is not progressing, it can be very well managed with bicontact lens, and as Dr. Jahandia also mentioned, that there is no cone for which a contact lens is not made. So in mild cases of irregular astigmatism, specialty custom soft toric contact lens can also do wonders, and for advanced cases we can use RGPs and scleral lenses. So the goals of ectasia management, the aim is first is the cessation of progression that can be achieved by corneal collagen cross-linking, and as my colleagues have already discussed the procedure, visual rehabilitation is very important in these cases since the patient was initially wanting a surgery to get rid of glasses, so they expect a good quality of vision. Contact lenses post treatment as well as intracorneal ring segments are an important tool in managing these cases. At last, the keratoplasty is the only option. Final visual rehabilitation is a combination of treatment. The goal is first to stabilize the cone and prevent the progression of keratoconus. Second is to flatten the cone and reduce the refractive error, which can be taken care using Intacs or the intracorneal ring segments. And the third is to correct the refractive error, aiming emetropia. Corneal collagen cross-linking. This procedure consists of photopolymerization of the corneal stroma by combining white B2, that is a photosensitizing agent, with ultraviolet radiation. The process increases the rigidity of corneal collagen and thus reduces the likelihood of further ectasia. And like we were discussing earlier also, Dr. Dipali also mentioned that in post-LASIK eyes, it has been seen that corneal collagen cross-linking causes, more of strengthening of the tissue. And increase in the biomechanical strength of the cornea by inducing additional crosslinks between or within the collagen fibers. The procedure has already been explained. And the intracorneal ring segment act as a passive spacing agent which will flatten the cornea. They are made up of PMMA and are available by various names. The most commonly the ones we use at our center is Intacs. And the principle, as very well shown in this diagram, is that steepening or on the segment body and flattening or on and in between the segment tips. The ICRS functions by repositioning the corneal tissue, steepening the incision meridian and flattening the perpendicular one to reduce the astigmatism and higher order corneal aberrations. The normal cornea, the mechanism is that it works by shortening the arc length of the cornea, and the smaller the diameter, the greater the correction, and the amount of correction depends on the ring thickness. More thicker the ring, the more is the correction. Now the question is, the Intacs alone is not going to work in these cases. The question is that to combine Intacs with C3R, whether sequential procedure is better or a simultaneous one is the better one. CXL followed by ICRS, progression is arrested by corneal collagen cross-linking, corneal rigidity is improved, and the corneal shape is normalized by the ring segment. Mechanical flattening effect is less than predicted by ICRS that has been seen, and a delay of 6 to 8 months in visual recovery has been observed. Whereas in the simultaneous procedure, maximum mechanical flattening effect is seen and the further progression that will be arrested. It is more than a simple additive effect, so it gives a synergistic effect. That is, it is increasing the biomechanical rigidity and the pattern and distribution of collagen. It changes after the ICRS. Also, it has been seen that the areas of increased riboflavin concentration between the ICRS segments with increased collagen cross-linkage. The advantages of the simultaneous procedure are that it results in rapid and predictable visual recovery. Greater improvement is seen as 1 and 3 months post-operatively, which is maintained from 6 months to 12 months, and there is no increase in haze or channel deposits. Single sitting procedure, the procedure can be completed. You don't need to call the patient twice for repeating the procedure. The challenges in cases of post-LASIK eyes is that the response can be unpredictable in some eyes. Also, we have to delineate the flap edge and the centration of the flap, and it can be difficult in cases where there are eccentric flaps. Measuring the flap thickness and planning the segment depth accordingly is an important and a crucial step. Care during insertion of the segment in the tunnel, as ICRS segment may enter a false plane between the flap and the stroma. Care to be taken not to displace the flap. And single segments, we have seen that single segments, depending upon how much is the irregularity, what is the astigmatic error, single segments also do well in few cases. And as there's the saying goes that prevention is always better than cure, and my colleague has already touched upon the role of extra procedure combining a PRK, LASIK or SMILE with C3R in borderline cases we frequently practice at our center. And these indications have already been discussed. So, to conclude, I would say that careful screening is necessary before planning a refractive surgery. Combination of strategies, ICRS with CXL, can give good results and can be customized for each case and provide a good final visual outcome. New modalities of combining CXL with laser vision correction, like we were discussing in the discussion, can be used in selected cases, although I've not seen them being practiced at my center. Thank you.
Thank you, Dr. Yoganki. So, any questions from the audience? Yes, ma'am.
I would like to know what would be the post-operative follow-up of a regular case of LASIK. So to find out if they have this post-LASIK ectasia, because as you said, without any risk factors, they may develop. So how frequently the topography needs to be done?
So, since Dr. Dipali covered the diagnosis, would you like to take this question? Yeah.
So routinely we follow up after surgery. We follow up at 1 week, then 1 month, then 3 months, then 6 months, then yearly follow up. But immediate post surgery scanning is important so that later on you can compare. If you don't do the immediate scanning, post op scanning, what I felt while making this presentation and reading all articles, no, I think 1 month. Few papers have reported 1 month. So they compare the baseline scan, then 1 month scan, and then progressive scanning whenever patient presents with a increase in myopia or astigmatism. So that can give you a clear picture.
If the 1 month scan is fine, then you review. Repeat the topo at
1 month scan will usually be fine because
Fine.
patient will
3
present
months.
after maybe 1 year or
Okay.
maybe 6 months.
So-
So then we investigate whenever patient is developing some problem, like whenever there is increase in astigmatism or myopia, or there is any symptom like patient is complaining of reduction in vision or poor quality.
Yeah, that time
then we
would
can do. Yes.
But before that, as
Before that we will
regular-
compare it with the 1 month post op.
So the 1 month scan is
Ideally.
done to we have a baseline examination.
yeah.
So suppose there is a range of normalcy, right? So suppose if you have a lower normals in your elevation map, and in 3 months the patient comes with some complaint, and you have little higher normals as compared to your 1 month, so that can give you a red flag. You might not diagnose ectasia in such patient, but you know that there is something happening in the healing, or it's a healing process maybe, but the ectatic signs will not be without signs and symptoms. So patient might be having some refractive error which you might get. And one thing I do in my patient, I do contrast sensitivity as well. So many times you will feel that the quantity of vision, that is Snellen's for patients reading 6/6, but when you compare contrast sensitivity from 1 month anyways, lot of time contrast sensitivity is not 100% post smile or LASIK. Suppose in 3 months the contrast sensitivity is 100%. In 6 months patient is saying that my vision is not as good as it was, and then you check the Snellen's is 6/6, but contrast is around 98%. And when you do the tomography, you see that elevations are different from the 1 month elevations. So these are the red flags which can tell you that maybe something's happening in the corneal stroma. So these are the flags we can look for. And the
Contrast
frequent,
sensitivity, the Pelirobson chart, or
yeah,
which
you
one
can have a simple basic, because you need to compare. When the patient is normal, you don't have to go for any specialized procedure, but 100 to 97 is obviously a significant change. You should have contrast sensitivity to 100% by the 3 months of the procedure, because obviously you are dealing with stroma, and contrast sensitivities are not full usually in a month treatment. So in 3 months usually I think that my patient will have 100% contrast and everything. But if this is changing, after that, then you have to question that why it is changing. It should stay 100%, right? So these are the first sign, which is a very subtle sign. Then the elevation that Dr. Dipali said, that in 1 month you take the normal map and you compare with that. If your elevations are increasing or worse than the 1 month, it should not happen, right? So these are the risk factors. So then we can have a close follow up, because nothing will happen in 3 months. For example, if the patient is a female, get pregnant, then you cannot say that 3 months is a very big time. Then we cannot predict. Male patient, non-pregnant female, no hormonal problems, you can have a close follow-up of 3 months or so and keep doing a topography. And the moment you feel that the refraction is there, astigmatism is there, elevation is there, I think post-LASIK ectasia always progresses. Keratoconus can be a stable procedure so many times, we can observe. But post-LASIK ectasia, bound to progress in most of the cases. So it's better to do the surgery or do the cross-linking in such patients rather than leaving the patient and having a very thin cornea in later stages and going for the keratoplasty. So this is my opinion about your question.
Okay. Thank you. Thank you, ma'am.
Any other question we can have it? I think we're before time because Dr. Jhanji talk is also over, so we can leave the room for the next team. And any question, most welcome. You can mail us. You can always talk about these things. And I would definitely need a feedback for my surgical cases, which I have presented, that if you decide something other than what I have decided for my patients. So it will be a great feedback for me.